Well, thank you very much, James, and thank you very much for the opportunity to speak. I was struck as I was sitting listening to both Dr. Wilkes and Mr. Mundie as they were describing what in essence I guess I see as policy directions and directives. And unfortunately for what I do on my daily basis, either A, I'm taking care of patients, or B, I'm actually trying to manage a whole group of physicians and actually get them to behave in ways that they ordinarily, at least deep down inside their hearts, really don't want to do. And I think when it comes down to actually talking about a lot of these issues, many of them are behavioral, and they, as Dr. Wilkes has already suggested, they really harken back to a time where doctors had complete and individual autonomy with how they took care of their patients, and they also had a one-to-one relationship with their patients. And that day and age clearly, as Mr. Mundie has said, is coming to a close. It probably hasn't been able to be functional for many years, and it certainly won't be functional going forward. So, and I think that the point that Dr. Wilkes made with regards to the fact that we really need to distinguish the difference between health care, and health care delivery, because those are three very different concepts and three very different things when it comes to dealing with patients. And speaking either as a patient or speaking as a physician, each of those have very distinct parts that are important, but they're important in very different ways. With regards to the issues of the use of metadata, clearly we do need a better way to deal with the data that we have today. At some point I hope we get to ask each other questions, because I'm not sure how we manage the data we already have and convert that into metadata at some later point. It seems like we're going to have a huge backload of information, just as the UPMC has spent a large number of dollars and time taking old patient records and serially digitizing every single one of those to convert them now into a digitized record that the patients can access. I think part of the other thing that I would, and going back to this issue of health and defining health, patients have to be able to define that health. And I think that's the essence of what Dr. Wilkes was saying. The patient has to decide what is health in their own minds. And oftentimes what I may think of as good or bad health may be something entirely different to the patient. So there is going to be a personal part of this. And while some cases that's going to be very good, people will decide to do the right things. In many other cases, and I'm sure nobody in the EU sees these kind of patients, but in the United States, we see a number of patients who like to eat very high-fat diets. They visit McDonald's all the time. They smoke, they don't exercise, and then they come to the healthcare system and say, I don't understand why I have all these problems with my heart and my digestion and et cetera, et cetera. Somehow we as a society are going to have to deal with that. That's not a problem that physicians alone can deal with. We simply will not be able to deal with that problem, and unless we face that as a problem, we're quite likely not to be able to move forward in any really sensible way. In terms of, so that it goes back, I think, to some of the behavioral issues that I talked about earlier. One of the things that we've tried to do along those lines at UPMC, you know, we stand in a very unique position because we stand on both sides of the Atlantic. We have 2 hospitals that reside within the EU and 20 hospitals that reside inside of the United States. In those 2 EU hospitals, we have pushed to become as similar to the style of management that we use at the UPMC natively or domestically in the U.S. One of them is now the Health Information Management Society, HIMSS, has a rating scale. And they rate how far hospitals are along in their progress to becoming electronically either dominated or completely driven by electronics. And our hospital now in Sicily, in Palermo, is a level 6, and the scale basically goes from 0 to 7, 7 being completely electronic, 0 being completely paper-based. So we've managed to move that hospital in a location that I think many would argue would not be a place that one would initially think of as the most appropriate place to put in a very high level healthcare system for the delivery of liver transplantation. But that's exactly what we've done. And it has worked very effectively. So if we now take that and say that we've learned a tremendous amount by doing, or at least by introducing, those forms of healthcare, one of the other activities that we've learned with regards to the ways in which you can interact directly with the patient and to empower, as Dr. Wilkes and Mr. Mundie both said, empower the patients to manage their care. We have an electronic access for the patients through a portal, and that portal is called Health Track, and I have a portal for myself. What you can do in Health Track is it allows you, the patient, to now go in. You can access all of your record. You can see and double check and make sure that you agree with the allergies that have been recorded. You can see all of the medications that you're currently been prescribed. You can also, if it comes time for you to get your prescription refilled, instead of having to call the office or whatever it is, you simply log in, you go to your page on the portal, you find your drugs, you say, click, 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 I want these refilled, boom, it's done. That then goes to the physician for an electronic signature. The electronic signature from that point is sent directly to the pharmacy electronically, and then literally within 2 hours you can go and pick up your prescriptions. You've never had to interact with anyone. You've never had to deal with driving in, facing the traffic, etc. And so that's one example of ways in which you can use the information as it exists today and using many of the techniques that we have at our disposal today to actually change the way people behave and to improve the way, if you will, that they behave. That is, we also know, because we keep records on the patients, we can't go back and find an individual patient, but we can tell you in aggregate that the patients now, the number of times that they miss filling a prescription, or the number of times that they don't get a prescription filled, has dropped by almost 35 to 40%. And that's a very simple tool that you can use that will affect outcome and will affect patient behavior. I think the other aspect, which we've touched on but we really haven't addressed, is the issue of clinical trials. And one of the things that allowing us to aggregate data in an anonymized fashion is that it allows you to now go back in and use that data in ways that you can either use it from an epidemiologic perspective, or you can use it to screen for other types of disorders, or look for patients who have particular types of disorders, and then approach them for being in clinical trials. The availability of that data and having it at the time and at your disposal at the time when you see the patient cannot be overestimated. Our own internal reviews show that we've had about a 35% increase in the number of people who participate in clinical trials because they can actually see the same data that we can. We can show them their data on the screen, and we can show them how they fit into this particular clinical trial and how it would benefit them if they were in that trial. So you have that whole other segment of this. And last, we have invested a large amount of money in telemedicine. And the reason that we've done that is quite simple. And that is, most of you probably don't know anything about the state of Pennsylvania, but it is located in the northern half of the United States. That's number one. Number two, it's also located near one of the Great Lakes. And one of the side effects of the Great Lakes is that it produces about 3 times more snow than it should for the given latitude that you are inside the United States. So for all of the patients who have to come to Pittsburgh, which is about 145 kilometers away from that area, which is Lake Erie, they would have to, right now, they would have to go through somewhere in the neighborhood of 2 to 3 feet of snow in order to get down to Pittsburgh. That's not a viable option for a lot of these people. The other part of this is that, as we were talking about aging populations, the Allegheny County is either the oldest or the second oldest county in the United States. It's the oldest county during the summer when all of the snowbirds come back from Florida and move back up to Allegheny County. And in the winter, we become the second oldest county when they all move down to Florida, and Dade County becomes the oldest county in the United States. That means that you have mobility issues, you have issues regarding how they're going to be able to get into clinics, et cetera. So we've had to use telemedicine. And one of the other issues that I think Dr. Wilkes touched on, and in regards to the fact that there aren't enough doctors, it's clear there are not enough doctors. I'm aware that the LCME, which is the licensing and accreditation body for medical schools in the United States, as well as the ACGME, which is the accreditation body for graduate medical education in the United States, are both on track to begin licensing overseas medical schools and residencies beginning in 2015. And so at least in part, I can tell you that what the United States is getting ready to do is to take all of your doctors and move them to the United States. Because I can pretty much read into what it is that they're trying to do there. They know they don't have enough physicians, they know they don't have enough medical schools, and they know they don't have enough residency training slots, so they're just going to go out and take all of yours. That doesn't have, it's clearly not my policy, but I am observing what they're going to do. And I think the other side of that is that we need to begin to utilize, and this is also has been spoken about by a number of policy experts in the United States as well, we need to begin to move in the direction of having ancillary health providers. So in the United States, we have a whole variety of people who have bits and pieces of medical care that are overseen by physicians. And if we have to continue to move down that pathway, because as Craig has correctly pointed out, there is no way that there are going to be enough physicians to care for everyone in the future. And what you do need are people who are well-trained and are well-skilled, who can then contact a physician at the drop of a hat if they need to through telemedicine or other similar types of approaches. I predict that at some point we will simply give up calling it telemedicine, because within another 15 or 20 years it will simply just be medicine. The tele part of it will just be gone. It'll just be the way you always have seen your doctor, and I guarantee you for your grandchildren, they will never know that you actually had to drive someplace and to go see their physician. That will simply never occur to them. As we move forward, I think there are a number of ways in which we can improve using, even if we take a lot of the technology that we have today and begin to apply it in a more sensible fashion, we can do a much better job of delivering much higher quality health care. And the last thing I would leave you with is, if you have a cold, or you have an earache, or you have a kid who has an earache and they're tugging on their ears, and any of you who've had children have all lived through that, there's nothing worse than the crying child at 2 o'clock in the morning. We have now, also in that same health track area, we have what are called e-health visits. And it allows you to come in and with any one of 20 different relatively minor symptoms, you check what your symptoms are, you check also whether or not you have ancillary symptoms that would suggest you really do need to be seen, that it's more serious than simply a sore throat, etc. But if you meet all of the regular criteria, you'll actually, that then fires off an email, which then goes to either your physician, or if it's in the middle of the night, it's usually a covering physician, who will get back to you within 2 hours. And you never have to make the visit. And if there's a prescription needed, the prescription is already, again, it's sent electronically. So those are ways in which we can really begin to facilitate that transition. Obviously, having hospitals now on both sides of the Atlantic, we look forward to working on this project either through the MOU between the EU and the US, or by golly, if you want to come down, either come over to Dublin or down to Ismet, we'll be happy to work with you there as well. Thank you.